On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Workarounds, Trash or Treasure. My name is Bob Yonish, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Dr. Ellen Deutsch serves as Medical Director of the Pennsylvania Patient Safety Authority. In this role, she is responsible for analysis and education based on data in the Pennsylvania Patient Safety Reporting System, better known as PA-PACERS. She's also the editor of the quarterly peer-reviewed patient safety journal, the Pennsylvania Patient Safety Advisory. She also serves as a senior scientist for the Children's Hospital of Philadelphia. Dr. Deutsch practiced as a pediatric otolaryngologist for 20 years and served as Director of Perioperative Simulation and Systems Integration for the Center for Simulation, Advanced Education and Innovation at the Children's Hospital of Philadelphia. Dr. Deutsch has held leadership roles in international and national professional organizations, authored more than 40 peer-reviewed articles, and more than 50 peer-reviewed chapters, editorials, and reviews. She has successfully developed innovative educational programs that leverage emerging technologies such as simulation to improve the skills and judgment of individuals and teams, patient safety, healthcare quality, organizational resilience, and healthcare delivery systems. Ellen, now I'll turn the program over to you.
Thank you, Bob. I think there were some tongue twisters in there. I'm going to talk about workarounds, whether they are trash or whether they are treasure. I know that workarounds can provide benefit and be good, or they can be problematic. So we're going to dig into that a little bit today. Our objectives are to list at least 2 hazards created by workarounds, 2 benefits provided by workarounds, and to understand how information gathered from workarounds can bridge the gap between work as imagined and work as done. We know that workarounds are ubiquitous in healthcare. Healthcare providers will use workarounds to circumvent or temporarily fix workflow hindrances or system design deficiencies. If they see a flaw in a process, they will create a workaround to fix it. We also use workarounds to cope with exceptional patient care circumstances or to accomplish a goal or sometimes to achieve that goal more easily. One way to think about workarounds is that they are non-standard processes that don't follow either the explicit or the implicit organizational rules. And I have a few examples taken from the PACERS reporting system. The details have been modified so that the confidentiality of the reports is preserved. But here's an example where a nurse was unable to scan a barcode before administering a medication because the barcode was incomplete. The nurse called the pharmacy and was instructed to type in the patient's name and medical record number and document confirmation of the medication manually. So this was a workaround that benefited the patient who received the medications appropriately, but the process didn't address the underlying problem, which makes this a first-order workaround. In another example, the barcode reading indicated that the barcode was invalid. So the nurse spoke with pharmacy, who determined that in this case, the reason was because the medication was non-formulary. So pharmacy approved overriding the error message and administering the medication. The pharmacy also requested that the event be reported to the facility's incident and serious event reporting system. So this is an important step because both the patient benefited, but in addition, documentation was requested which could support future investigation and mitigation. These are a couple of examples of workarounds that work to the patient's benefit. Here's another example. After signing out a high-risk medication, the nurse brought the medication to a patient in respiratory isolation. Once in the patient's room, the patient's bracelet was scanned, but upon trying to scan the medication, an error message was received. And the nurse discovered that a portion of the barcode was missing, and therefore the label would not scan. So the medication was given, and then the nurse returned to where the high-risk medications are stored to scan an undamaged one for documentation purposes. And at that point, the scanner indicated that this was not the correct medication for this patient. So in this case, the workaround bypassed a safety mechanism and created a hazard for a patient. So what processes do we see involved in the workaround events that we receive? We receive reports of workarounds related to health information technology, and this is consistent with the national literature. But I think that some of this is because the electronic health systems allow us to capture very granular data, and so they may perhaps be overrepresented in the workaround reports that we receive. We do also see workaround reports based on medication doses being based on estimated weights rather than actual weights. So a weight estimation is a workaround for some particular circumstance. Sometimes we see reports of consents for procedures being obtained from surrogates rather than the actual patient. And sometimes we see reports of substituting equipment or medication or other resources when there are shortages. And I think there's some kind of workarounds that we actually don't see reported all that often because people don't think of them in the same way or think about reporting them. So, for instance, if there's a shortage of equipment or supplies, then sometimes people hoard them, and that is a workaround, but that's probably less likely to be reported through the PACER system, although it probably should be. So why do providers use workarounds? Well, we know that healthcare has a workaround culture, and we value expertise in overcoming obstacles to get the job done. Providers may well curse the darkness, but they will work hard to find a candle to light. And we know that healthcare providers are dedicated, motivated, smart, and creative, and they may feel it's their ethical and professional responsibility to accomplish a task for a patient despite needing a workaround to get there. And so then why are workarounds even needed? Well, there are sometimes impediments to providing the best patient care. Sometimes there are discrepant perceptions about how care should be provided. There could be mismatches between how processes are understood and implemented or how resources are allocated. Or there could be resource constraints. Novak and colleagues describes two frames of perception about how work is done. One is the system frame, which is the frame that vendors or developers or implementation decision makers may make, or the frame that they may have of how work is accomplished, which may differ from the bedside care provider's perspective, which is the practice frame, which results from an aggregation of the provider's experiences. Another way to think of the same concept is to think about the gap between work as imagined and work as done. Work as imagined is the conceptual state, maybe the ideal state, sometimes illusory. This might be what designers or managers or regulators or authorities believe should happen or does happen in the abstract. And this becomes the basis for design, for training, and for control of processes. But there's also work as actually done, work that truly occurs, and this may have to manage varying circumstances, diverse patient conditions, and real-time knowledge about resource availability and even goal conflicts. Healthcare delivery is a complex adaptive system, which means that it's impossible to truly understand every single action and the ramifications of that action within the healthcare system. So providers are continually adjusting how they work. They're dealing with resource constraints. They're dealing with changing environmental conditions. And the system that they work within is not static, and so any action taken by somebody within that system impacts other people, whether they're patients, whether they're providers, whether they're managers, whether they are leadership. There's always a dispersion of impact through the system. Conditions constantly evolve, and it's not possible to anticipate all the consequences of process or resource decisions. So what is the value of workarounds? Well, workarounds are usually implemented to ensure patient safety and well-being and provide efficient care. There's an example that Gersis and colleagues wrote up about a nurse coordinator clipboard, and this was used as a transfer of information from the outgoing to the incoming nurse coordinator at the end of each shift. And this clipboard included an accumulation of data retrieved from multiple sources on a paper-based tool. And this tool was useful to the nurses despite the availability of an electronic medical record, because the workaround, the clipboard, made information access compatible with the mobile nature of the nurse's work. It enabled rapid information access, and it enabled documentation under time pressure, and supported the layout of the clipboard allowed rapid information integration and understanding. So how do we recognize workarounds? Well, sometimes there is explicit evidence, such as posted notes or visual reminders. Sometimes there's implicit evidence, such as when providers don't follow an established process or guideline or protocol and use alternate procedures. In some cases, workarounds may be obvious. This photograph is from the Amtrak crash just outside of the train station in Philadelphia that occurred a couple of years ago. And as a result of this event, about 200 patients were taken to local hospitals. So this was a surge in patients that was unexpected. It's very likely that the care providers balanced the goals that they had to achieve and took care of the critical patients as the acute process, and deferred some of the documentation tasks until later. So a workaround may represent elastic adaptivity, where a lower order goal, such as the documentation, is temporarily sacrificed to accomplish a higher order goal, which would be taking care of the patients. However, workarounds can become routine, and that can make them hard to recognize, and they may persist undetected for long periods of time. As we saw in our examples, workarounds can cause hazards. The short-term hazard may be a result of breaching an intentional barrier. There may be a purposeful and appropriate safety intervention, and the workaround could create a hazard for a patient. There's also a long-term potential problem with conducting workarounds, which is that a workaround suggests that there is a problem with how the system is organized, or maybe a missing resource. And if the workaround is successful, then people who may be able to change that system may not be aware the workaround was required. And so this can also allow an unsafe system to persist. So this adaptive problem solving of workarounds is actually a double-edged sword, because it may prevent a failure in the short run, but it may obscure a design flaw that could be remedied with providing a more long-term solution. And a successful workaround may limit the awareness and the ability to investigate and mitigate a problem. In addition, if the workaround actually is an improvement, then people may not be aware of the possibility of making the system better, and so the diffusion of the improvement may not occur. Whether or not the workarounds help or harm in the immediate clinical care situation, they do contain useful data. So this is the famous picture from Dr. Bob Weers. On the right side is the recently implemented electronic patient tracking system, and on the left side of that image is the old-fashioned handwritten whiteboard, which contains a lot of embedded information, even in the details of abbreviations, or maybe how things are spaced, or other sorts of codes. And you can see that the providers here are voting by their actions. Everybody who's looking at the board is looking at the old-fashioned board, and nobody is looking at the newer board. And so this provides an opportunity to investigate what is it about the handwritten board, what sort of information is provided that could be translated into the electronic board. And the workaround may also illustrate goal conflicts. So is the purpose of a particular task to provide patient care, or is it to provide data for administrative purposes? So then the question is, do you adapt the provider's actions to the workaround, to the practice, to the system, or do you adapt the system to the provider's practice? So the workaround gives you information to help you reconcile the design, the function, and the of the processes to real-life workflows. Workarounds can serve as input for user-centered design and can help align the work as done with the available tools and the resources. And workarounds can sometimes provide organizational solutions particularly for exceptions that recur. So understanding why the workaround occurs and understanding what the desired goals are is important information. This is a typology from Friedman and colleagues, and I think these are useful questions to ask when you see a workaround. One is whether the workaround is temporary or routinized. Two is whether the practice has the ability to eliminate the underlying circumstances, or whether these are external circumstances beyond the practice's control. And three is, was the workaround strategic and deliberately chosen, or was it an unplanned adaptation? The image in this photo is from a meeting that I attended, and I thought it was interesting that there was such a simple workaround to solve my problem, according to the app, of having no friends. All I had to do was tap the Add a Friend button, and it would be lovely if all solutions were this easy. But recognizing that they're not, functional resonance analysis method, or FRAM, is one of the methods that can be used to look at the components of a process, such as implementing a clinical guideline, and making sure that all the pieces really are in place in a way that a workaround might not be necessary. So this was used when implementing clinical guidelines in a couple of intensive care units in different countries. The FRAM model is not based on a specific model of how work takes place, but it's used to understand the relationships in socio-technical systems. So in this model, you see that the input is what starts or impacts the function. The function is the process that you want to accomplish, and the output is what emerges from the function. The other parameters help you understand what the mutual dependencies are. So what are the time constraints that impact the function? What conditions must be satisfied before the function can begin? How is the function controlled or monitored? And what resources might be required to conduct or accomplish the function? And here's an example of how the FRAM method was used to understand the interrelationships in a process of an intra-facility transfer of a patient. And we're going to take a closer look in a second, but this often resonates with healthcare providers because it does demonstrate complexity and interrelationships, which we all know exist. We cannot always map a process necessarily as a simple linear function. So we're going to take a closer look just at this corner of the FRAM. And as you can see here, the top left is the evaluation of patient condition, at which point there's a decision that the patient is ready for transfer. The next box in the lower left corner is setting the transfer date, and you can see that an outcome of setting the transfer date is contacting the bed manager to make sure there's a bed, setting the date in the electronic patient record, selecting the ward, et cetera. So these are all outputs of that function. But you also see that there's a resource, the opportunity for a resource in setting the transfer date, and maybe that resource is a person who's needed to enter information, or maybe that resource is bed availability, or maybe bed availability is a precondition. But in any event, this allows the receiving ward to send back information to say what they need in order to be prepared. So again, the point here is that there are a lot of interrelationships, and this is one model that can help care providers look at processes and develop questions. And one of the important things about this model is that these questions can be explored with those, not just providers, but other people. It may be managers, it may be people who are making sure that the beds are cleaned, but that all those who are participating in the functions have input into what processes are required. So the challenge of workarounds is to capture their positive aspects. Say that we don't understand the processes that we're implementing correctly and completely. How can we make the best use of the workarounds that may ensue? So looking at why they happen and what's positive within them is helpful, but simultaneously we need to avoid pitfalls of ad hoc solutions or first-order solutions to long-standing problems that don't necessarily incorporate the complexity or the unintended consequences of changes. So as demonstrated both in the examples that were provided at the beginning and as you can conceptually understand from this presentation, there is the opportunity to collect information and evaluate information about workarounds in PACERS. And harm score A, or unsafe conditions, may be the appropriate harm score for an event that's submitted about a workaround, or it's possible that harm score B may be appropriate if the event is prevented from reaching a specific patient because of active recovery by caregivers. And it's possible that there may be other circumstances in which other harm scores are appropriate. But regardless, a description of the workaround in PACERS is very helpful, and even more than just describing the event, describing its impact and perhaps even changes that were planned or implemented as a result of the workaround will add to our body of knowledge. So to summarize, individual workarounds may be seen as either problematic or pragmatic. And that's interesting because the workaround may start off with the same intention and the same actions. So a patient may have an undesirable outcome even if we do the right thing. Or conversely, we may inappropriately take a shortcut, but the patient may still be okay. So we have to be careful how we look at workarounds and keep in mind the perspective of the person who initiated the workaround at the beginning of the process. But I think we should avoid thinking about workarounds as errors or mistakes or deviance or shortcuts when they're intended to solve workflow obstacles. So we should think about workarounds as symptoms of real or perceived workflow obstacles and address them in that manner. Analysis of the context and the circumstances of the workaround is very important, and that's what I think can provide us with valuable information that may lead to improving the efficiency, the effectiveness, and the safety of healthcare delivery processes. So I did put all my references in here. If you wish to look any further, there are 3 pages of references. And then at this point, I think I can open this up to questions.
Thanks, Ellen. That was a great presentation. It contained valuable information I think everyone in our audience can use in their organization. That concludes our slide presentation portion of the program. If you have questions, please type them in the Q&A box found on the right-hand side panel of your screen and direct them to all panelists, and we'll try to get to as many questions as we can. Ellen, I can think of situations where a workaround started in my prior life as a temporary due to maybe an acute situation, and then eventually turned into routine practice. How do you get staff to recognize a workaround?
I think it takes an awareness and a thoughtfulness about the work that you're doing. So if somebody is not following the standard or the endorsed process, then that suggests that there's a workaround. And I think we all know about these things. And it may be just that describing what workarounds are could help people recognize them. But I'm sure many of us can think of situations where a certain piece of equipment is known to be in short supply, and so there is an extra one stored in a special place, or maybe even a secret place. There's a workaround. If you see stickers or explanations or Post-it notes with instructions, then that may suggest that there's a workaround also. But again, I think people will become sensitive to them, one, if they hear some examples of what they are, and two, if they feel like recognizing and reporting workarounds will lead to process changes that make the workarounds less necessary.
That brings up another question. I know that nurses can either be praised or punished depending on the situation. Similar to the barcoding example that you described earlier. Can you discuss that contradiction?
Well, the challenge there is that we look at the actions with hindsight bias. So we know the outcome, and if the outcome was good, then we may want to believe that the process was correctly selected, and if the outcome is not as optimal as we would have wished, then we'd like to find a place in the process where a problem occurred. And if there's a workaround, that might be an easy place to find blame, but it may actually be that the problem that contributed to the need for the workaround is many steps back in the process or is multifactorial. But I think the key is to maintain the perspective of the person entering into the situation. It's very hard to unknow the outcome, so I think it takes some intellectual vigilance. But you're right, we can do the right thing and have a bad outcome. We can do the wrong thing and have a good outcome. And so I think the value here is in exploring what happened and why it happened, and learning from it so that things can be changed in the future so that that situation doesn't occur again. Of course, we cannot predict every situation, so some of this takes learning in a generalized sense rather than learning a specific rote process.
I want to thank everyone for joining us today. This concludes our webinar.